Welcome back to the Skinfluence Podcast. I'm your host, Dr. Dustin Portela, board-certified dermatologist.
And I'm Austin Lee, a physician assistant who works alongside Dr. Portela every day.
And it's summertime. We're recording this just after the 4th of July. Hope everybody had a great holiday. And we're going to be talking today about some of the more perplexing things that we see in dermatology that I think we don't get credit for as being, people who diagnose some of these weird autoimmune conditions that come out on the skin.
We see a lot of autoimmune, a lot more than the average person would think of autoimmune conditions. And these are some of the most fun things for me to see in clinic. They're some of the most fun things to diagnose in clinic. Not the most fun thing for our patients to be struggling or suffering with, but these are complex puzzles that often take multiple specialties to treat, but very often it's dermatology that's making that initial diagnosis.
Yeah, sometimes we're leading the charge, so to speak, before systemic findings are occurring due to these autoimmune diseases. And essentially, what is an autoimmune disease? Basically, the immune system of the body is supposed to recognize things that are foreign or cancerous and fight them off so that they don't take you down. You don't become sick. You don't develop systemic cancer. And that's what the immune system is supposed to do. But in some circumstances, what happens is it mistakes your own normal tissue for something foreign, and it starts to attack normal parts of your body. And that's when disease develops. And we'll make a distinction between autoimmune and autoinflammatory. I don't know if you want to take that one.
Yeah, so autoimmune is really where your immune system is seeing, like you said, something within your body that is normal as foreign and attacking it. And it's an attack on the body. Whereas autoinflammatory is where your body is eliciting inflammation incorrectly.
Yeah.
So you're getting a lot of red, irritated, angry bumps or rashes on the skin. That's inflamed, angry skin. Whereas very often with autoimmune conditions, you may not see just red, rashy skin. You'll see more blistering. You'll see more patterns in the skin, or sometimes you'll see some redness in very specific areas alongside systemic symptoms like fatigue, joint pains, other types of things like that.
So when it comes to autoimmune, basically there's so many different autoimmune conditions. They tend to affect women more than men. And the skin is often involved because there's a lot of different proteins in the skin. It is a barrier to the environment. And so it's easy for the skin to be an innocent bystander and get attacked. And it's the most visible way that we can see an autoimmune disease. Whereas if autoimmune disease is attacking your kidneys, that could potentially be going on for a while before symptoms develop, but we can often see it more quickly in the skin.
Yeah, and like you were saying before, in autoimmune conditions, they're very targeted to specific types of proteins or cells in our body. And very often the skin shares a lot of similar proteins and a lot of similar cells to our internal organs.
Yeah.
And so you'll see manifestations of it on the skin.
Probably the most common autoimmune condition that people are aware of, maybe due to house or somebody else, is lupus.
Yeah.
So lupus, we think of systemic lupus, but there's a lot of different kinds of lupus. We've got cutaneous lupus, subacute cutaneous lupus, discoid lupus,
Tumid lupus.
There's a lot of different kinds of lupus. And so let's maybe kind of break down some of the skin findings of what lupus are.
Yeah. Well, we'll start with one of the more benign cases, which is discoid lupus. Discoid lupus is typically of the face or scalp, and it's an attack on the skin where you get these circular little red rashes, and sometimes it can be a solitary little plaque just sitting on your skin for years, and it can affect the ears, the conchoid bowl of the ears or the scalp, and it doesn't very, very rarely does it translate into systemic lupus, so a very low incidence of it turning into full body lupus. But it's something that should be on our radar because the singer Seal has scars on his face because of discoid lupus. So it can be disfiguring, it can cause scarring, and so it's even though it may not be like a life-threatening type or a life-altering type, whereas it can affect your joints and things like that, it can leave lasting scars.
Yeah. We had a nurse in my residency program, and she had scars, and I had thought maybe she just had bad acne, and I just asked her one time, I was like, what are those scars from? She's like, oh, I had discoid lupus. And her face was very scarred from it, and she was a great nurse. So it's one of those things that you do want to catch early if possible. Sometimes it has to be a biopsy before it started to leave the obvious carpet tack sign on the skin and getting scars. If we can catch it early and treat it appropriately, we can prevent some of that scarring. The most common presentation of cutaneous lupus that people think of is going to be that butterfly rash, where you get bright red plaques appearing over the cheeks and up over the bridge of the nose. And I've had people come in thinking that, do I have lupus? And they just had a sunburn or a photoreaction from a medicine they were taking. But that butterfly malar rash is a very classic sign of cutaneous lupus. And that is a key feature of lupus, is that the sunlight tends to exacerbate it and make it worse. And so people with lupus have to be very careful about their sun exposure. And some people are so sensitive that even fluorescent lighting indoors can cause flares. And I remember growing up in the church that we went to, every once in a while I'd show up and the lights would be dimmed. And I was like, what's going on? And they're like, oh, this lady's here today and she can't handle the fluorescent lights.
Interesting.
And she was usually homebound. And so we would have to dim the lights in the chapel for her. So
interesting. Yeah. It is a very photosensitive condition. Very often we have patients who have rosacea, which also flares in the sun, come in thinking that they have lupus. Other types of lupus that we'll see, subacute cutaneous lupus is one of them that you mentioned, where you see this kind of serpiginous, circular, flaky rash on the chest and upper back. Your classic lupus with the butterfly rash. Tumid lupus will show up kind of as like these hives or welts that are on the body and trunk.
They feel deeper in
they
the
feel
skin.
hard.
They're like palpable.
Yeah. So there's all sorts of different types of lupus. I've had quite a few cases of discoid lupus, and people will say, well, I need to do labs. I want to make sure that there's nothing else going on. And very often with discoid lupus, there's not labs that are going to be distinctive for that.
But with any type of lupus, I'll always entertain a workup to make sure the kidney function is appropriate. They're not getting chronic kidney disease. They don't have blood in the urine, that their liver enzymes are appropriate, that they're not at risk for blood clots, things like that I think are reasonable. And if we start to see anything amiss there, we'll work with a rheumatologist or their internal medicine physician to help manage and lower that risk, because individuals that start to develop systemic lupus have a much higher risk of kidney disease, of heart disease, and we don't want to miss those things. And many times the skin appearance is the first manifestation of something going on.
Totally. Moving on to the next common condition that we see, rheumatoid arthritis is another autoimmune condition. We see this in the clinics very often, but when you see this, we have a patient coming in, you suspect rheumatoid arthritis. What do you do for that patient?
Well, usually this is going to be what we call a rheumatoid nodule. So they'll start to develop bumps under the skin, oftentimes around joints. And unfortunately, this is often a late stage presentation of rheumatoid arthritis. In my experience, people don't get their initial diagnosis of rheumatoid arthritis because they show up with a rheumatoid nodule. This is ongoing, poorly managed disease. And I don't say poorly managed as like the doctor's not doing a good job, but it's just not responding to treatment. And so these patients often have that ulnar deviation of their fingers, where their finger joints are starting to erode and get pulled to the medial side, to the ulnar side. And they're severe joint pain. They have difficulty with mobility. And then they'll start to develop these large nodules over, really it can happen just about any joint on the body, but most commonly around the wrists, the hands, the feet, the ankles is where I tend to see them. But I've seen them on the elbows as well and around the knees. Yeah.
I had a patient once years ago who had lots and lots of rheumatoid nodules, and she just wanted them all removed. And so she'd come in and we'd do little punch biopsies of like 5 at a time, and then just kept coming back for more and more. But
yeah, and that's the tough thing, is you can sometimes alleviate what's there, but it doesn't do anything to prevent them from coming back or coming back in the exact same area.
Totally.
So
another condition that we can see in clinic is gout.
Yeah. And I have made this diagnosis a few times. So gout is a problem with uric acid metabolism in the body. And uric acid is something that you can get a lot of by eating red meat, by drinking beer in particular. Wine can cause it. And so in history, this was often called the king's disease, not to be confused with hemophilia, which is the royal disease. But like the king's disease, because they were the ones that would have the best food. They would be able to eat a lot of meat. They had all the alcohol, and they would sit on their throne. They wouldn't, they weren't out in battle moving. And so they were metabolically very unhealthy, and they would develop gout. And what happens is you have this excess uric acid in the body. And in colder temperatures, uric acid will readily crystallize. And so it will start to form deposits, particularly around the joints. And this is why we tend to see gout accumulating. We call them gouty tophi, which I'm not sure where that term comes from. It's kind of a funny term. But it happens in areas of the body that tend to be colder. So away from the core of the body. Think on the hands, on the feet. The classic presentation is at the big toe. And then on the ears is another common place for gouty tophi. And I've taken those off of patients before.
Really?
Yeah.
I've maybe made a diagnosis once, but
yeah,
it's pretty far and few in between for me.
Yeah. Oftentimes when I've seen them and we've taken one off, it's because they're tender and the patient already knows they have gout.
Yeah.
I don't know that I've made the initial diagnosis of gout because of a gouty tophi, but it is, kind of one of those unique things, and it has a very characteristic look under the microscope, especially if you polarize it. It's just really bright, shiny, like almost fluorescent when you do the right kind of microscope examination.
Yeah.
So
painful.
Very painful.
But interesting sometimes to see. And then the joint can go completely back to normal.
Yeah, it can if you get your uric acid down. And I think one thing that's unappreciated for people that have gout is high levels of uric acid often contribute to elevated blood pressure. So people who have gout often have higher blood pressure. And if we can get that uric acid down to more normal levels, that can be an important part of controlling somebody's blood pressure.
Right. The next one we have on the list is something called dermatomyositis.
Yeah.
And I did a rotation in dermatology at a clinic that saw a very high amount of patients with autoimmune conditions. And my next rotation was in family medicine, and I was writing a note, and I happened to have a patient who had a history of dermatomyositis. So I wrote, patient has a history of DM. But in the family medicine world,
that means something different.
That means diabetes mellitus.
Yeah.
And I confused my attending physician and got in trouble for that.
Yeah. You got to read the room, so to speak.
Yep.
So dermatomyositis is one that I've made this diagnosis a handful of times, and it is an autoimmune condition that tends to affect the skin, of course, that's the dermato part, and then the muscles, the myo part, and the itis is inflammation. So the classic presentation of somebody with dermatomyositis will be a shawl sign where they get a red rash over an area that you might wear a shawl on the upper chest, on the upper back, and it tends to be very itchy. They also get what we call Gottron's papules over the joints of the fingers. When we see lupus on the hands, it tends to be between the joints, whereas dermatomyositis tends to appear right on the joints with these thickened papules. And that's a characteristic sign. We also get what we call a heliotrope rash around the eyes, or raccoon eyes, sometimes we'll call that. They often have a very intensely itchy scalp as well.
Totally.
It is very common. And those are the skin findings of dermatomyositis. But there's also characteristic joints and muscles that are involved.
Yeah. So when we have a patient who comes in and you suspect dermatomyositis, very often then you ask, do you have difficulty combing your hair? And they say, yeah, my arm gets so sore. It hurts when I have to pull my hair, lift my arm up, my hand above my head. Or do you have difficulties going up the steps, like walking upstairs? And they will. And these are signs that the immune system is not just attacking the skin, but it's also attacking the joints, which is what we call it the muscles, because we call it dermatomyositis. Dermato skin, myo, it refers to the muscles. And so it is a multifactorial, multi-system condition that can be really, really painful and can sometimes take a long time to diagnose.
Yeah. Patients will sometimes go months to years before getting the appropriate diagnosis, and it can be pretty debilitating. And it tends to affect those proximal appendicular joints like the hips and the shoulders. So going up the stairs, like you said, getting up out of a chair. And sometimes if I suspect this might be going on with a patient and they're sitting on the exam table, I'll just ask them to stand up. Without telling them what I'm looking for, because I want to see if they can just stand up unassisted or if they have to push themselves up with their arms. And combing the hair, reaching for things on high shelves becomes very difficult. And this one can be associated with some internal malignancies as well. So if an adult shows up with dermatomyositis, we always want to know if they're up to date on their age-appropriate cancer screenings. Like if they were a smoker, they need a low-dose CT scan or at least a chest x-ray. They need to have a colonoscopy to make sure there's no colon cancer. They need to have, pap smears if they're a female that still has a cervix and a uterus. We may want to do a CT to look for ovarian tumors because ovarian cancer is highly associated with rapid onset of dermatomyositis. So this one scares us a little bit when we see it, especially if it developed rapidly, because we want to make sure the patient doesn't have an underlying cancer. And that is one of the weird features that might merit its own episode is perineoplastic dermatology, all these weird rashes that can happen when someone gets a cancer on the inside of their body.
Yeah, that would be an interesting episode.
Let's see. You want to talk about BP? I think
BP
might be good. It's not on there. So.
Yeah. Another condition that we see that's autoimmune is something called bullous pemphigoid.
Yeah.
And it's an interesting case. These are usually interesting cases because it's usually in the more elderly population, 65 and up, or very often associated with Alzheimer's. And they come in with with blisters all over their body.
Yeah.
And these blisters are incredibly itchy. They're very often, you come in and they pull up their pants is wet because there's so many blisters on their body. And this is an autoimmune attack on a protein that connects our cells together in the skin.
Yeah.
And as that degrades, it fills up with fluid that our skin is already holding there, and you become itchy and just miserable.
Yeah. So you can think of this protein, we call it BP230, and what's the other one, BP160?
I believe it's 160.
Yeah. So this is a protein that holds two cells together at the dermal epidermal junction between those two layers of skin. Think of it like like a zip tie holding them together, but the immune system attacks it and breaks it. And so now you have a space that occurs between the two layers of skin that will naturally just fill up with fluid. Often it'll fill up with blood.
Yeah.
It can initially present and look a lot like hives. We call that urticarial BP, urticarial, or hive-like bullous pemphigoid. And if you can catch it early, it's obviously going to be easier to treat. But I've had to consult on patients in the hospital who are covered, and it looks wild and scary.
Yeah.
And I had a patient in the clinic years ago who was starting to develop this. We had done a biopsy. We knew that was going on. They didn't really want to do much for treatment other than some topicals, and then had a really terrible flare. And I was on call for the hospital when they were admitted. I went in, I was talking to the patient, and they were basically ready to die.
Really?
Just psychologically.
Yeah,
like their health was okay. They're like, I've had a good life. And I'm like, just take the prednisone, you're going to be fine. And I still see that patient to this day. They're doing really well, but it can on its own last for 5 years, give or take, for some people before it usually kind of burns itself out, and we don't really know why that happens.
Yeah.
And some patients, it will continue even past that 5-year mark. But 3 to 5 years is what we commonly will read in the textbooks. But bullous pemphigoid is a gnarly one. And there's so many more we could get into. Pemphigus vulgaris, cicatricial pemphigoid, that all are the immune system attacking different areas on the body. And I only bring these up not to go in depth, but to talk about how, as dermatologists, we have to work closely with sometimes oral surgeons for pemphigoid that's occurring in the mouth, for pemphigus that's occurring in the mouth, or in the eyes. Cicatricial pemphigoid can lead to blindness if it's not appropriately treated. So we'll work with ophthalmologists to get the right immune suppression to save somebody's vision. And so many people think of dermatologists as pimple popper MD, but there's some pretty serious stuff that we do have to deal with on occasion. And thankfully, they're not really common conditions. But if you know somebody that's been affected by one of these, you know that they can be quite serious and quite debilitating.
And very often, primary care will be on the right track. They suspect these types of conditions, but rheumatologists are very often so booked out in popular areas, so they will send them to dermatology to try to get some treatment going. and we're happy to help in any way that we possibly can. But it is we work really closely with other specialties as well to try to manage these patients.
And then we want to contrast the autoimmune conditions with auto-inflammatory. And the characteristic auto-inflammatory condition that we deal with is going to be psoriasis.
Yes.
So a lot of people think of psoriasis as an autoimmune condition, and I've heard even dermatologists sometimes say that, but I know they don't mean it. Sometimes it's just easier to explain it to patients that way. But there's a few hallmarks of psoriasis that we see.
Yeah. So one of the classic signs of psoriasis is you see these thick plaques of red inflamed skin with what we call mycosis scale, this white fine scale on the top of the extensor surfaces. So places like the elbows, like the knees, like the ankles. We have conditions that are diagnosed with biopsies, and we have conditions that are diagnosed clinically. Psoriasis, if it's early or if it's being partially treated, we may need a biopsy, but very often it's a clinical diagnosis where they come in and we can just see based on the look and the distribution that this patient has psoriasis.
And so when we are evaluating a new patient with a rash, there's a few things that are going to arise more suspicion is in our assessment that they may have an autoimmune condition. We've talked about a few of those, but rashes that appear with systemic symptoms like joint pain that can occur with rheumatoid arthritis, with dermatomyositis, even with psoriasis. When there's other systemic involvement like blood in the urine, and I don't know if there's other things that you're commonly looking out for.
Well, yeah, like we've talked about, joint pains, difficulty with lifestyle, distribution of the rash, but yeah, those are kind of the more common things that I'm looking for as well.
Yeah.
What does your day look like is what I want to know. When you, like you said, when you're going to the bathroom, is there anything abnormal there? Do you have difficulty functioning on a daily basis? Do you have pain when you walk? Stuff like that will kind of help guide our diagnosing abilities and whether we need to do blood work and look deeper.
Yeah. And another key that I will have to say I'm not as expert in as I would like to be, and partly is because these diseases are not as common, but we can use our dermatoscope to look at the blood vessels at the nail fold. And there are different presentations. When we magnify right at your nail fold where your nail comes out, there's different blood vessel patterns in scleroderma versus lupus versus dermatomyositis.
Interesting.
And you can start to see what a normal blood vessel pattern should look like, but then when you start to see some abnormal findings, that can also be a clue that we might have something more autoimmune in nature going on. And that tells you that the autoimmune process is affecting those small blood vessels, and that's why it can also impact the kidneys or the eyes or a number of other functions inside the body. And so there's lots of little clues that we're trained to look for to, pique our suspicions that an autoimmune condition is going on.
Yeah. And this is one thing I love about dermatology is it's a puzzle, and very often it's there for us, in front of us to figure out.
Yeah.
And I enjoy that aspect of it and being able to help patients where very often when we see patients with autoimmune conditions, they'll come in and say, "You're my fourth dermatologist." And you want to be the last dermatologist that they see.
Yeah. And I love being in that position because oftentimes I look super smart.
Yeah.
But they're coming to me with, I know everything that hasn't worked,
Yep.
This person didn't do a biopsy. This person gave him a cream that didn't work. And so if I can come in and make the right diagnosis, I look super smart. But a lot of times it's just because I was the last person to the party.
Yeah.
And I knew what didn't work. I like to think I'm super smart, but I don't want to, get too big of a head. But that's really what's going on sometimes is I just already know what hasn't worked, and I might have wanted to do the same thing another dermatologist did. But it is nice when you can make that slam dunk diagnosis.
Yeah, it's true.
So, but we're going to move on to some things that you need to be aware of in treatment. But first, a little fun did you know? All right, so this one is something called autobrewery syndrome.
Autobrewery.
Have you heard of this?
No, I've not heard of this.
So this came when a gentleman was pulled over for suspected drunk driving.
Okay.
And the police pull him over and ask him if he'd had anything to drink. You were driving a little erratically, and he swears up and down, "No, I have not had anything to drink."
Okay.
So they get him out of the car. He fails the field sobriety tests. They make him blow on a breathalyzer, and he's twice the legal limit.
Oh, gosh.
But adamant that he did not have anything to drink. And so in seeing multiple doctors, he's describing many times where he feels foggy, like his brain isn't working well, his speech is a little slower and slurred, and he's not got the coordination that he should. And so he eventually, they do some additional tests, and they find that he had such an imbalance in his gut microbiome that he had overgrown with a type of yeast that would ferment carbohydrates into alcohol. So whenever he ate a carb-heavy meal, he would essentially
get drunk.
Even though he
Poor
did not
guy.
drink alcohol. Yeah. And so this is endogenous alcohol production, and it was because of significant microbiome imbalance in his gut. And so this was a case report. One of the only that I've ever heard of is auto brewery syndrome.
Wow. So he's a brewery unto himself.
Unto himself. I mean, that is a cheap date right there, you know, like,
yeah, that tab is
do you want
low.
a drink? No, just give me some more chips and salsa or breadsticks, you know,
some French fries. That's wild.
And so this guy was 46, and he had these types of symptoms for 6 years before diagnosis, with no significant psychiatric history, but he also aggressive behavior, which would happen after a carb-heavy meal, which was uncharacteristic for him. And yeah, it all like came to a head when he was presumed driving while intoxicated. So yeah, his blood alcohol level was 0.2 at the time.
No way.
Auto brewery syndrome.
That's crazy, man.
Yeah, pretty unique case. And there's probably people out there who that might be nice once in a while, but I think it'd be pretty debilitating. You know, you'd have to go keto, and so. Yeah. But yeah, they treated him with antifungal agents, and then gave him a bunch of high quality probiotics to repopulate his gut bacteria. And he remained symptom-free for 1.5 years, which was when they published this case report.
That's amazing.
Yeah.
So when he's feeling stressed and just needs to like let loose, he just has some carbohydrates.
Just have some breadsticks or something, which works for me too, but it's not because I'm getting drunk. It's because I like carbs.
Yeah. Well, mine's not as unique as that one is probably, but I had a case of a little girl. This was years ago when I was practicing in California, and she came in with what looked identically to linear IgA bullous dermatosis. And it was on her abdomen, and she had this, it looks like we called a string of pearls, like these round little necklaces of blisters that look like little pearls on her skin. Had my supervising physician come in and look at it and thought the same thing. So we did a biopsy, and the biopsy came back, and we did a DIF and all the different stains came back as mixed inflammatory. Couldn't make a solid diagnosis. Yeah. We tried treating her with topical steroids, and it just progressed. Every week she would come in, and it would get worse and worse and worse, no matter what we were doing.
Yeah.
And I'm working side by side with my attending. Like, this was something that we were both trying to tackle together. And every week she came in, and it was starting to creep up her face, and it was kind of going all over. It's getting into her mouth now, and could not figure out what it was. And then I don't know, one of us had the whim to swab it when it was a blistering, and turned out it was a really crazy case of Pseudomonas.
Oh.
That every week she was going to a lake called Millerton Lake in California, and she was playing in this still water that was kind of pooled off the lake.
Yeah.
Every week they'd go there because it was this perfect little place. The water was really warm.
Yeah.
And she just had this crazy looking infection that we were able to finally treat, but it took like 4 weeks
that is
of
really
us
wild.
Suspecting autoimmune condition, some autoimmune condition.
Yeah.
That's
wild.
kind of an interesting case.
Yeah, that'd be one to write up for sure.
Yeah. Yeah, that would have been good to write up.
As a consumer, as a patient, what you should look out for if an autoimmune disease is starting to develop. So let's talk about some of the warning signs that you can be aware of, things that we look for or that we might ask you about when you're coming into the clinic.
Yeah. So one of my main things is when someone comes in and I'm suspecting maybe a multi-system problem or an autoimmune condition, like we've talked about, I like to ask about lifestyle. Do you have problems waking up, getting out of bed? Do you have problems doing your normal things? Are you feeling fatigued? Like, do you feel like you have brain fog? Do you feel like if you're reaching for something and you're grabbing that carton of milk, does your wrist or fingers feel sore? Do you feel weak in your grip and things like that? If that is something that we all have times where we feel weak or we're feeling tired or fatigued or whatever, but if this is an ongoing thing that you just can't shake, and it's been a month and nothing's changing, or a couple months and nothing's changing, those are some of the initial warning signs. And then you'll start to see sometimes little rashes pop up on the elbows, or little redness on the knuckles, or my eyes are puffy all the time. There's a things like that where we say, this is not normal. And I think as humans, we have the tendency to believe, this will go away. I'm going to be fine. This is just, I don't know what's going on. I went hiking and I was in a bunch of pollen or something, and this is going to go away. But if it doesn't, that's when it's a little warning signs are going off.
Yeah. Another thing that you should look for is sun intolerance, basically. If you've been able to be out in the sun, and now even if you're putting on sunscreen, the heat, the UV is starting to cause a rash to occur. Photosensitivity is a really common presenting sign for many autoimmune conditions, particularly in lupus, in dermatomyositis. I remember in residency, we had a nurse practitioner that was working in our clinic. Patient came in, they had a rash that was, widely distributed, looked a little scaly, and the nurse practitioner thought that it was psoriasis, and so put the patient into phototherapy.
Oh, no.
And after about a week of being in the light box, this rash was just getting way worse. And now they saw the attending physician, and he was like, you have lupus, and we never should have put you in the phototherapy box because it's responsive to that UV light. It makes it worse.
Yeah.
So photosensitivity that is unexplained, that just all of a sudden starts happening, is another clue that you might have something autoimmune going on.
Yeah. Another thing that to look for is if you're starting to bruise a little bit easy. So if you're just like, all of a sudden you're getting bruises on the hands or on the legs, or you're starting to notice little small blood vessels popping up. You can see little red lines popping up on the skin. Or if you see you're tending to ulcerate, you're forming little blisters a little bit easier. And they may start small, or they may start as like a welt or something like that, and then they progress into a blister. Those can also be warning signs that you're developing something. And very often these conditions aren't all of a sudden one day it's full bore, your body's covered. They usually tend to start small, percolate, and get worse and worse and worse as time goes on.
Yeah. Hair and nail changes are another avenue to be aware of. We talked a little bit earlier about some of the nail capillaries, those small blood vessels that we can look at. But ragged cuticles, if you're not a nail biter, you don't have a habit of picking at your nails or pushing the cuticles back, but all of a sudden your cuticles are just ragged and they're just tender. Tenderness around the fingernails, that's another sign that it could be an autoimmune condition.
Yeah.
Your hair all of a sudden changing in quality, becoming more brittle, having significant itching up on the scalp, that can be another sign that it's autoimmune. And I know that a lot of these things that we've mentioned are very generic, and some of them can happen in non-autoimmune conditions, just having hives or psoriasis or eczema. And that's why it can be very important to work with a dermatologist when you're starting to develop some of these unique symptoms, because we certainly don't want to scare you and send you down the rabbit hole that you now are going to have lupus and you've got 5 years before you need a kidney transplant or something. But there's a lot of nuance to this, and these are just kind of broad, general symptoms to be aware of. And if you're being treated for a common condition and you're experiencing some of these and your symptoms are not getting better, it may be reasonable to get another opinion.
Yeah, totally. And when you come in and you're expressing these concerns, it's important for us as providers to have these things on the back of our mind, even though they're not things that we see very often. If we suspect them, there are things that we can do to help kind of guide that diagnosis. And then if it is something beyond what we feel like we can manage here, we will send you to the right people. But very often we will, if we suspect dermatomyositis or these other conditions, we'll start running lab work, we'll start doing biopsies, we'll start doing things to try to get you answers as to why you're experiencing what you're experiencing.
Yeah. And this is where biopsies can really come in handy, or there's so many labs that can be ordered. And I try to be really cautious about labs with patients, because when we start doing workup for immune system conditions, they can get really expensive. We
Yes.
start doing not just a regular biopsy, but Austin talked about a DIF, or a direct immunofluorescence biopsy, where we have to take a biopsy from usually the edge of the rash. We send it in a different solution, and they have to look at it under a certain type of fluorescent lighting, and they're looking at IgA, IgM, IgG, and different things to see, like, what is your immune system doing, and where is it potentially attacking? And if it's positive, there's certain patterns that we'll look at that will lean more towards lupus or dermatomyositis or bullous pemphigoid. And the labs are endless, essentially. We can look at so many different markers in the immune system to see if you have antibodies. Most everybody has heard of an ANA test, or an anti-nuclear antibody, as one of the most common things that can be positive if you develop lupus, but it's often positive in many different autoimmune conditions. It's not very specific. So having a positive ANA that your family doctor checked doesn't tell you a whole lot about what is going on. It just tells us it may be autoimmune, but it's also positive that up to 30% of women can have a positive ANA and have no autoimmune conditions going on.
Yeah.
And so that's where we start to get into other more specific tests, like a double-stranded DNA, anti-SSA, anti-SSB, SCL70. There's dozens and dozens of tests, and they start to run up the cost pretty significantly. And so we like to do the biopsies first and be judicious about lab ordering to hopefully guide us in the right direction without ordering one of everything and costing tens of thousands of dollars to you or your insurance company.
Yeah. And what we're trying to do very often is try to make the diagnosis as early as possible when we're doing these biopsies, when we're ordering labs that we feel are appropriate, because we know that these conditions can often take years to accurately diagnose. Patients are suffering for years during this time with these conditions and the unknown of what is going on with my body. And so it's our role as providers to try to get the answers. But even sometimes with early conditions that we suspect, we highly suspect some autoimmune condition, but the labs aren't quite positive. The biopsy is really nonspecific. And so even then, sometimes it'll come down to our clinical judgment to say, listen, I know that everything is kind of broad. There's no slam dunk diagnosis, but let's try to get you better by treating you for this condition I suspect you may have, if appropriate. We don't want to jump the gun and start throwing heavy-duty immunosuppressants or anything at people who don't need them, but we want to get our patients as comfortable as possible while we're trying to figure out what's going on.
Yeah, and earlier treatment is going to prevent a lot of problems. If you are on the road for lupus or dermatomyositis or rheumatoid arthritis, if we can intervene earlier and get you on appropriate therapy, our goal is to help eliminate or reduce the chance of kidney damage, of heart damage, of blood clots, of other sequelae that can happen with some of these. And that really is the role of a dermatologist, is that rheumatologists, I just don't think there's as many of them as dermatologists.
Yeah.
We are trained in the use of many of the same medications for immunosuppression. But when you have both skin and systemic disease, meaning internal disease, you're usually going to be served best by being managed by both specialties. And we work pretty well together. And in fact, in places like the Mayo Clinic, they have a joint derm room clinic for patients who have these autoimmune conditions, so that when they go for their visits, they can be seen by both specialists in the same day. And then the specialists can consult together and help to come up with the best treatment plan. And that really is the role and the goal of most autoimmune conditions, is to have involvement in this multidisciplinary care.
Yeah, we know that these conditions have emotional impact on our patients, and which is why places like that will offer multidisciplinary care, which is why we tend to work closely with our rheumatologists that are local. And our goal is to try to treat our patients with the best care that is possible for them.
Yeah.
And understanding that lives are being affected, our patients' lives are being affected, and it's our job as medical providers to help them get better. And sometimes it can be very, very difficult with these conditions because they start slow and they progress slowly. But that's why we're here, to help emotionally support our patients through these difficult to treat conditions.
And it's important to have realistic expectations. If you are diagnosed with one of these conditions, in many times they can last 3 to 5 years, but some of these diagnoses will be lifelong conditions that now have to be managed. And that's another thing that can take an emotional toll on a patient, is it radically changes the trajectory of your life, and now it has to revolve to a degree around a disease that you have to make sure you have your medication, that you go to your visits. And so long-term care is usually expected, even in the ones that will resolve, being 3 to 5 years is not trivial by any means. So we understand that, we empathize with our patients that are going through these kinds of things, and always try to stay on top of the literature, the newest research, and make sure that the best care is happening. And in some cases, we can pull strings and get people into, the rheumatologist or the gastroenterologist, a little faster when something is deemed to be, life-threatening or critical. So as we wrap up, we want to share our product of the week this week. And this really kind of just speaks to the skin barrier care. And this is important when you have autoimmune disease, because you've got so much inflammation in the skin. And so today we're talking about the Aven Thermal Spray and Aven Sequelphate Plus. These are really great for the skin microbiome. They're very soothing. They're fragrance-free. They will come in sterile packaging. And so when you open them up, you're getting a sterile product that you can put on the skin. These are also great post-procedure, which is not something you're usually going through when you're having an autoimmune disease. But if you've had your face lasered or chemical peel, these are great products for that. So really excellent for skin barrier repair, soothing red, irritated skin, whether that's from autoimmune disease or some other condition. So we'll have links to those in the podcast show notes and in the YouTube video description. We appreciate you guys joining us for this conversation, a little bit longer today, but an important topic. And if it's been helpful for you, share it with a friend who might be going through autoimmune skin disease or autoimmune disease in general. Leave us a 5-star review wherever you listen to podcasts. I'm Dr. Dustin. You can find me on all social media platforms at Dr. Dustin Portela.
And I'm Austin Lee. You can find me on social media at Austin Lee, PAC.
We'll see you next week.